So this first triage, we get these signs and symptoms. If it's an urgent referral, they're going to go straight to hospital and they'll do something.
Yes.
And I think, we talked about this earlier on. It's not our role or responsibility, but we're talking about MRI within 4 hours, aren't we?
That's right, yeah.
And certainly I've had consultants on the show before who said they would get out of bed at 2 in the morning if there was a possible Cauda Equina, even though there's a good likelihood it won't be Cauda Equina syndrome.
Yeah, yeah.
So, they certainly were taking it that seriously. What about this one here? This is one that's progressed to bilateral. Now we're going urgent referral to MSK triage. What does that involve?
Well, it depends where you live, and that's what makes this whole discussion a little bit more challenging. Certainly where I am in Nottingham, I would refer my patients to the Queen's Medical Centre. They have a specialist spinal unit, and within that spinal unit they have a spinal triage service. So patients who go into ED or A&E will, as soon as there's a mention of potential Cauda Equina, they'll be bypassed through A&E and into the spinal triage team, who will do things like MRIs, bladder scans, neurological assessment, as a separate unit rather than in an A&E department. If you don't have that facility in your local practice and in your local area, and it's worth finding out what your local spinal service is like, then I would suggest, if you suspect Cauda Equina or an emerging Cauda Equina, just send the patient to ED. Let them make the decision about who and where they get triaged further. You certainly don't want to be going down the GP route, because we all know at the moment, for all sorts of reasons, seeing a GP is difficult and not always quick. And what you don't want to be doing is sitting in front of a disciplinary committee saying, well, it's not my fault it took 3 weeks for the GP to see the patient. Yeah. We have a responsibility to hand over if we suspect something like this. And hand over means not send a letter in the post or send an email. It's literally to hand over to somebody who's going to then take the case forward.
Yeah, I was going to say, my recent experience of going to A&E with my father, who fell over and broke his hip, was that there were an awful lot of people standing waiting to get to the desk in A&E. And if we sent a patient there, the patient would have to say the right things to make sure the person behind the desk knew what they were supposed to do with him, I thought.
And we'll talk about that, because again, there are ways that we can circumvent the standing at a desk trying to explain to a receptionist why you're there, and there are people to speak to.
Okay. Right, so we've had our urgent referral to MSK triage. If it's less than 2 weeks, presumably less than 2 weeks since the pain spread bilaterally?
Since the onset of the worrying symptoms, yeah. Right,
which is the unilateral pain spreading bilaterally, not the first presentation.
Yes.
Right.
Yes.
So now they're going triage the patient for Cauda Equina, which will involve the MRI and other
bladder scan. So one of the techniques that's used to establish whether there is bladder competence is what's known as a bladder scan. So it's essentially like an ultrasound of the bladder. The patient is scanned pre-void, and then they go off to the toilet, they void their bladder hopefully, and if there is a retention of more than 200 mils within the bladder, that would be considered a positive bladder scan. In other words, the patient is not emptying their bladder. There is an issue with the competence of the bladder sphincters, and therefore that would escalate the urgency.
Right, so that doesn't prove Cauda Equina syndrome.
No.
It simply means you've got to go and look harder and see if there is a compromise somewhere.
That would be one of the steps towards building a case for doing something or not doing something. So if the patient is able to void and empty their bladder, then likely they've got reasonable control of the sphincters, and therefore your index of suspicion drops down. If it's retained in the bladder and certainly more than 200 mils, that ramps your index of suspicion up, and then you go for your urgent MRI scan, and then you put all these bits of information together.
Which is presumably the gold standard, the MRI, because you will clearly see whether the situation in the spinal column matches the symptoms that the guy's the
and most specialists now would agree that you cannot diagnose Cauda Equina syndrome without an MRI scan. There has to be radiological concordance.